Hey everyone, welcome to Pain Consultants USA podcast number 10. Tonight, Dr. Bonner and I are going to be discussing peripheral neuropathies. These are very common issues that we see in many of our patients. It's obviously much more common as patients go through life. It can be a cause of significant lower extremity, more so than upper extremity discomfort. Can interfere with quality of life, especially sleep. So tonight, Dr. Bonner and I wanted to discuss, you know, what a normal presenting situation may look like, how we might diagnose this, give you guys some treatment pearls on how to kind of recognize this early, even before you see your physicians, and then ultimately how we can treat this and improve your quality of life. So, that being said, good evening, Dr. Bonner.
Good evening. How you doing?
I'm good. I'm good. It's a little cooler where I'm at than where you're at this evening.
It cooled down a little. It's in the 70s now, so
I don't know how you do it. I don't know.
it's tough. It's tough.
Um, okay. With peripheral neuropathy, I guess let's get right into it. What do the patients look like? How do they present to your office most commonly? What should patients be looking for?
Yeah, I think the most common thing that we see with peripheral neuropathy is that patients come in complaining of some type of symptoms in their feet. Most commonly, some numbness or some tingling, or my feet feel like they're asleep, or my toes feel like they're asleep, and even sometimes some burning pain also. Um, Generally, like I said, starts in the toes and the feet. Um, and eventually, if it was worse, it might progress up the legs a little farther. And if it got pretty far up the legs, it can also start in the hands and things. But most commonly, patients would notice something kind of when it was really just encompassing the feet. And we see a lot of those symptoms at nighttime usually. So sometimes during the day the patients feel fine, but then they're in bed and they say the symptoms start when they're in bed and they really get kind of terrible and they're uncontrollable, and sometimes they even say like they can't have the covers on the feet because it just feels really weird for them. So that's kind of the most common thing we see, and the as the presenting symptom. And then the thing that often accompanies that, especially in the United States, is a history of diabetes. So it's very common in patients with diabetes. It's probably more than 95% of the patients that we see in our clinics with peripheral neuropathy are probably related to diabetes. Some of the other common ones might be excessive alcohol intake. Um, but in the United States, I would say diabetes is probably number one. And if they're not diabetic or they don't know they're diabetic, you might have to test and tell them later on that they actually are diabetic and they didn't know it. So that's those are the main things I'm thinking right away when a patient comes in with those symptoms.
Yeah, I think overwhelmingly, majority of the patients will complain of symptoms in both feet. Um, it just kind of starts and gradually gets worse, and everybody notices it worse in the evening. Um, I always tell patients the primary reason you notice it more in the evenings is the same nerves that um, give you sensation, when you're walking around during the day, give you kind of feedback where your feet are, what you're doing. They're the same nerves that are affected in most cases. So at nighttime, you're not doing anything. There's no other sensory input coming in to the system, and all your brain and central nervous system has to kind of focus in on is the abnormal signals from the neuropathy. Um, it's the most common reason why it's worse at night. And would you agree with that? It's a pretty
Yeah,
basic explanation, but
yeah, I always wonder about if there's a vascular component to that too, because we see a lot of arterial problems in patients with diabetes, and and I wonder sometimes if maybe kind of when a patient lays down, they're not getting blood flow to the feet like they are with gravity kind of pulling the blood down to the feet during the day, and maybe that's affecting the nerves too. I don't know. I don't know if that's ever been shown or spoken about or disproven, but I wonder about that too sometimes, because sometimes people with peripheral arterial disease get worse pain at night because when they lay down, there's less blood flow kind of to the feet if
Mhm.
the peripheral arterial disease is really bad. So, I wonder if that's an issue or some component of it too. But I don't know that that's ever been kind of shown or shown to
Yeah,
be false.
it,
So
it might explain why some patients do like just have like the abnormal temperature
yeah,
sensation component
hmm
to it as well. Again, oftentimes, we might say the feet are a lot colder at night or
right,
different things like that.
right,
The other key thing is usually this will start it's symmetric.
yeah,
So meaning both feet. I'll see at least one patient a week who has back issue but numbness in the foot, but it's on one foot, and they're asking me, well, I'm not diabetic, why would I have neuropathy? And usually um, my quick answer is, well, if it's on one side, I don't think we should necessarily attribute that to a peripheral neuropathy per se. I think there's
right,
other explanations to have numbness in one foot.
right,
um, Taking a step back for a second, when we use the word or the phrase peripheral neuropathy, we're really talking about the nerves in the extremities, right? Kind of where the nerves exit the spinal cord and kind of travel down the leg. So that's your peripheral nerve. For people who might not understand the basics of this, those nerves, right, there's two big groups. There's motor nerves, so they're the nerves that give you strength, and then there's sensory nerves. So if you touch your leg or someone touches you, you can sense that something just touched you, right? So there are two big groups of nerves, and depending on the disease, sometimes you can have issues that affect the motor nerves, sometimes the sensory nerves, or a mix of both. The other thing you always want to think about is each of these nerves, they're just like a wire with, and the electrical wires in our walls in our home or office, where there's an insulation around the nerves and then the actual wire itself. And the insulation helps to coat and conduct or transmit the signals faster, and the wire itself is, the response and how big of a response.
right.
So you can get issues in the insulation, or you could get issues in the wiring itself, or both.
Right.
Um, so just a little more kind of some of the basics of peripheral neuropathy.
Yeah, and some of those different issues, if we can determine what the issue actually is, help us kind of delineate what type of neuropathy it is. So, and then what's causing it, basically. So that that gets a little more in depth and can get it can be very difficult sometimes to figure out what causes this for some patients who aren't diabetic, and so sometimes the type helps us determine or the type of issue with the fibers like you're talking about helps us determine what causes it. So,
Yeah, and for the purpose of this podcast, we're primarily talking about acquired neuropathies. Right?
right.
There's hereditary neuropathies that's a whole other talk, and I think we probably should talk about that in the future. But tonight, hereditary neuropathy, so something that develops, or sorry, acquired neuropathy, something that develops with time. Most common being diabetes. I would agree. Alcohol abuse or heavy or excessive alcohol intake, even if you don't identify as an alcoholic, can be neurotoxic.
hmm
Um, Kidney disease is another probably more common one in the United States, and critical illness. Long hospital stays, being in the ICU, can affect those nerves. Some of the the things we had to learn during our training, and you're always kind of pimped on or questioned on, would be
Hmm.
the rare vitamin deficiencies or things like that. But
Right.
in developed countries, they're much less common.
Leprosy. I think leprosy is still listed as one of the most common causes of peripheral polyneuropathy, but I don't think in the United States that's not the case. That's kind of in other third world countries where that happens, but
Yeah.
that's still a question that I think we get on tests every now and then. Um,
Exactly. I think the one other thing that I hope we talk a little bit about tonight would be small fiber neuropathy as well, and
okay.
we could talk about how that's a little different. Um, but so we mentioned diabetes, so we'll start there. Uh, I have some patients where they'll say they're pre-diabetic, and they've been maybe pre-diabetic
Yeah.
for years, right? And you still kind of pick up some subtle neuropathy. Do you see that a lot? Where even though they don't have full fledged diabetes or their sugars are relatively under control, that yeah, they'll still kind of develop a neuropathy.
Yeah, definitely. I've definitely seen that. I think, like I said earlier, sometimes you patient starts complaining of the neuropathy symptoms, and you say, well, are you diabetic? They say no, and you say, well, and when have they checked? And they haven't checked recently, so let's check. And then you see that they're pre-diabetic, or maybe they are diabetic and just haven't figured it out yet. And so then you say, well, it's probably related to this, and so you need to treat this, because often with neuropathy, the treatment for neuropathy is generally control whatever is causing it first and foremost. So that it's always something to keep in mind when you get a patient coming in with those symptoms. Do you have diabetes? No. Have you been checked for it? If not, we need to check you for it, because it's going to be the most common thing. And sometimes you might just be in that range where we say what we currently call as pre-diabetic. And I think those ranges have changed, year to year. The number, I think the test we use is called the hemoglobin A1C typically. And that's kind of a more recent test, and by saying more recent, really the last 10 to 15 years. I think I remember in medical school that, they were saying, oh, this is the new guideline. We use this now. We used to use different tests. Now we use this. And so that number for where you're pre diabetic or diabetic has also, that range has kind of changed a little bit over the last 10 years, if I'm not mistaken. And so maybe that range continues to change. And some of these people who are pre diabetic are actually diabetic.
Mm-hmm.
But there's the damage is still being done regardless.
So on examination, patients with neuropathies, obviously, we're checking strength, make sure they're not weak. Again, you notice if the issue affects some of the motor neurons, right? Those nerves that give you strength, you could pick up some subtle weakness in the feet, ankles. You might even see some atrophy of the muscles, especially if the neuropathy has been present for a long time. And what do you normally see with like your sensory exam? Like what do you typically look for, and what are some things that maybe patients can do at home to even check like their own sensation?
I mean, I'm typically looking for, kind of classically what we say is like a stocking glove distribution of symptoms. So if they say numbness, I'm going to start at the toes and try to see if there is true numbness. So, we can test for different types of sensation, um, light touch versus a pin or something, some sharp object. Um, the other types of sensation that we talk about sometimes might be vibration. So, if we have a tuning fork available in the office, we can assess the patient's ability to feel vibration. We can also assess something called proprioception. Proprioception is your ability to assess kind of where in space your body is without being able to see it. And a way to assess that with your feet would be to take your toe, move it up or down, and with you not looking, ask you to tell me which way I've moved your toe. And so, that's maybe something you could have a family member check for you if you think you have some of these symptoms. A vibration, if you don't have a tuning fork, I'm not sure if you could test that at home, but, and I don't think most people carry a tuning fork around.
Uh,
Um, and if it's really obvious, of like you could just not feel someone kind of lightly touching you with like a feather or something, like a Q-tip or something like that, a cotton swab, that might be one way to assess it. So those are the things
yeah,
I'm looking for with the sensation, and then like you said, the strength. I think to see strength deficits, we usually expect it to be a little more progressed, but definitely assessing the strength for patients. If you're noticing that your feet have gotten smaller or the muscles look smaller, that could be something. If your feet are getting flatter, maybe that's because the muscles are getting weaker. So you could see a lot of different things there.
yeah. And with regards to the sensation, like you mentioned, the stocking like distribution loss. So again, both feet and the farther down the legs, usually the sensation is affected more so than farther up the leg. So whether if it's just in the toes, well then above the ankles or in the shins and calf, it's probably normal. If you notice the numbness halfway up your shin or calf, then a lot of people will say, well, when I touch my thighs, above my knees, that feels normal, but below does not. Um,
Right.
so, and then we should make the distinction between um, what would be painful, right? So, a neuropathy, it can affect your sensation. So, you could have abnormal sensation, but you can also have painful sensations, right? So, if you have pins and needles, but it doesn't really affect your quality of life, doesn't affect your sleep, yeah, as long as you're managing your disease or whatever is causing it effectively, I mean, you could just let it be. I mean, I guess what we're going to get into with regards to some of the treatment options would be, if the symptoms cause pain, cause emotional distress, or any quality of life issues or sleep, that's when you actually want to treat it with some medication.
Right.
Is that right? You don't treat neuropathy. You don't treat just the abnormal sensation that doesn't interfere with quality of
No,
life, correct?
only if it's interfering with sleep or, function, then yes. But otherwise, if the patient's fine living with it and they feel okay, then I'm okay with that. Another thing we should say is, it's in diabetes, it's a slowly developing phenomenon. It's not a rapidly progressing problem. So if you develop these symptoms of numbness and or weakness in both legs, starting in the toes and progressing up the legs, and it progresses quickly within hours to days, and then also including the hands, that's something that is not common diabetic peripheral polyneuropathy. That can be much more severe condition, something like what's known as Guillain-Barré syndrome. And so, if you're developing a condition like that, you really want to get to your doctor or probably the emergency room as soon as possible. So, if you have this condition and it's developing very quickly, you need to probably go to the hospital ASAP. So that's just something, diabetic polyneuropathy is much more slowly developing. And if I saw a patient who said this was developing over a couple days, I'd be much more concerned about some other type of problem.
Exactly. I mean, those warrant urgent or emergent workups. Again, these kind of acquired neuropathies of chronic disease states happen over years, most commonly, or you might notice it in a year or so goes by and things are gradually getting worse. So yeah, that's a good tip.
Yeah.
Um, I don't routinely always order EMG tests to confirm the diagnosis of peripheral neuropathy, especially if the history and exam and symptoms all fit.
Right.
I would agree. I would assume you agree with that.
Yeah, I completely agree. I don't think it's necessary, um, especially like you said, if we're not going to treat it and it's not progressing and it's fine, we'll just keep an eye on it. And if we are going to treat it, I still will try a few things probably before I would order an EMG or nerve conduction study to assess for the neuropathy and kind of fully document what type of neuropathy it might be. Of course, if it was progressing faster, like we said before, that would be more of a trigger for me to order a test. But if it's pretty stable and slowly progressive, I would elect probably not to order a test.
Yeah. I find myself ordering the EMG when maybe the exact cause of said neuropathy is unknown.
Yeah, if they're not diabetic, I'll
Mhm.
order one very frequently. But if the patient's diabetic, I probably will just kind of watch and wait, unless the patient's really pressing about it or something else kind of unusual is going on, like we mentioned before.
Yeah, I mean, a lot of these, a lot of patients have more than one issue going on too. So even if they're diabetic, but we know they have some lumbar spine issues, and we're trying to figure out, well, they haven't responded to certain treatments. Well,
Hmm.
maybe sometimes an EMG could be useful in that regard.
Yeah.
I know we've spoken in detail before about EMGs, about who should do them, and we won't kind of go through that again. But again, the one tip, and this is more of a personal belief, is you should know who's performing your EMG and nerve conduction study. It should not be a physical therapist or a chiropractor. This should be done by a licensed physician, whether it be a neurologist or a physiatrist. Um, and again, it's each state is different. It's interesting. You can look into your own state laws on who's allowed to perform EMG and nerve conduction studies. But I know in the state of Pennsylvania, physical therapists and I believe chiropractor offices can do them.
Yeah.
And again, when they're doing uh, the needle portion of the study, if they're just doing that surface and they're not actually sticking a needle in you, um, then that kind of clues you into that you probably should go somewhere else, because the
Yeah.
test is probably not going to be that valid.
The one that I've seen in Florida more commonly is like a diagnostic center where they do the tests, and then so they'll do the nerve conduction part of the test that way, and and then a physician will later look at the data and interpret the data and give a report based on the data. And you know it's conceivable that you could come up with a good study that way, but it's definitely not going to be nearly as good as if a physician who's experienced doing this test does the test after taking a history from the patient and examining the patient. It's just going to be so much better that way every single time than any of these other ways. So I would,
Yeah,
be skeptical if that's the kind of test that you're getting.
yeah, and I think it's fair to say, at least in my experience, when tests are done by providers who maybe should not be doing this, or these kind of centers, I feel like uh, there is over diagnoses or
Yeah.
diagnosis of certain conditions. So
Hmm.
these studies all typically have numerous findings that you typically wouldn't see on normal studies. So again, red flags. This just leads patients to having to have this test done multiple times
Hmm.
to get the correct answer. So again, for the patients listening, you have to be your own best advocate and understand who's doing what to you at all times, and you know, don't be afraid to speak up and say no, or answer a few more questions before we go down this road.
Yeah, definitely.
Um, so
Is
let's.
there
I
any other
mean,
tests that you would consider?
sometimes. So I guess we'll kind of jump around here to like small fiber neuropathy,
Hmm.
right? So in patients who have really bad neuropathy, and usually these patients will have a lot of like burning pain and dysesthesia or different symptoms that really do impair quality of life. And it, smells like, looks like neuropathy. You get the EMG test, and it's absolutely normal.
Yeah.
In those cases, sometimes I'll order a skin biopsy
Hmm.
to look for small fiber uh, disease.
Yeah.
It's there are tons of different nerves in the body. Again, the motor and the sensory nerves that we mentioned that these EMG tests or most neuropathies affect. There are larger fibers, but there's also small fibers that sense pain. Um, so those fibers are not, even if there's an issue with them, EMG tests don't pick that up. So the way to isolate that would be you could do a skin biopsy, and under a microscope you could see um, some specific findings that would kind of clue you in as to small fiber disease.
Yeah.
How about yourself? Anything?
Yeah, I don't think I've ordered a skin biopsy. I have a few patients who I strongly suspect small fiber neuropathy, and kind of all of their testing has been normal, and so we just treat it as such and just kind of, um, you know, go forward that way. Um, but yeah, I mean that would be this. I would order the same test if I was really, having an issue and not really sure what was going on. But um, I think by the time you get to that diagnosis, you've kind of ruled out all the other major stuff most of the time. So I just don't tend to go farther with it. So
Yeah, I mean, you especially if the clinical scenarios, right? You've probably ruled out peripheral
yeah,
vascular disease as well, or arterial disease. They've probably had an MRI of their low back.
yeah,
Uh, you know, so you're right. Usually, it's the other kind of systems that would potentially cause those issues have been
yeah. I know I have a
thoroughly
few of
evaluated.
those. I have a few of those patients, and um, it's kind of hard to get it across to everyone else who's treating them, because by the time they come see you, they've seen the orthopedic surgeon to say, "Oh, is this a back problem?" And they're like, "No," and like they've seen the vascular surgeon, and probably, I have one lady I know who had like a bunch of procedures on her veins that didn't change anything, and then like all her arteries were fine, so like, well, it's not your arteries, and so then she's kind of going around in circles, and then you tell her this, and you're just, maybe that in that case, it's a good thing to get it to prove to everyone, okay, stop doing any other testing or any other procedures. Nothing else is going to be useful. Let's treat this as small fiber neuropathy. I could see that being a good time to order that test. And I do have a couple of those people who have kind of gone around in circles for a while saying, what is this? What is this? What is this? And I don't think too many people are trained to look for it, and they've had the EMG and they're like, well, the EMG is normal. Well, the EMG is normal in this case, so it's not the right test. So maybe we need to spread some awareness or something.
Yeah, sometimes even like peace of mind for the patient.
Yeah,
It
yeah, definitely.
it can drive them crazy, and they're like, "Well, it can't be in my head. Well, what the heck is it?"
Hmm.
So,
Yeah,
um, okay, well, I guess transitioning to treatment. A lot of the treatments that we're gonna touch on, we've mentioned in other podcasts for other various neuropathic pain issues. But if you can kind of give me your treatment algorithm for the medications you use, and maybe when you choose which ones, and kind of go from there.
yeah. I'd say that I think like some of these other things we've talked about that are nerve related, I tend to start, especially if it's at night, with gabapentin. I try that out. It tends to be, decently tolerated. And if it's not tolerated, the most common side effect is that the patient's a little drowsy. And if the symptoms are at night, it's kind of perfect for that. Puts them to sleep a little bit and maybe helps with the symptoms. Um, uh, if that doesn't work, pregabalin sometimes, if the insurance will cover it. Uh, And then, like we've talked about, also some of the tricyclic antidepressants. If the patient's not older than 65, I might start with a low dose of amitriptyline or nortriptyline. And I found pretty good success with those, I think, especially with the nighttime symptoms. Um, that's kind of most commonly what I'll start with is those medications. What about you?
Yeah, definitely. I think gabapentin is, I would say, most people's first go-to. Definitely mine, especially at nighttime. Again, majority of the patients, nighttime symptoms are the worst with neuropathy. So,
Yeah.
uh, and so then, one of the issues with gabapentin is there's a huge dose range.
Right.
So there's 100 milligram pills and there's 1200 milligram pills. So
Yes.
where the heck do you start? My general rule of thumb is if patients aren't getting benefit at max 600 milligrams 3 times a day, I don't usually go up from there.
Right.
But I, as long as say patients aren't 70 or older, I'm usually starting at 300 milligrams at night.
Right.
Maybe for my over 70, I might consider 100. Other factors that would go into play there would be if they have kidney disease,
Yeah.
right? Kidney disease, you definitely have to lower the dose, and there's some guidelines to what would be safe and appropriate.
Yeah.
Um, if they are older, but they're on a lot, let's say they're on opioid medications for other issues or, some pretty powerful medications, I might feel a little more comfortable starting at a little higher dose of gabapentin rather than 100. So, I always start at night though. Usually, if they can tolerate it, a slow titration up might be every 4 to 7 days, add in a pill. So
Mm-hmm.
go from nighttime to morning and then afternoon.
Yeah. It's a little tough
Or
sometimes, because um, also we tend to say that, you might take gabapentin for a few weeks before you really start to see an effect. So, so sometimes that's hard to explain and it's hard for patients to understand sometimes because they'll start taking it and they'll say, oh, it's not doing anything. And within a week, they just stop taking it. And you might see them a month later and say, how's it going? They're like, oh, I stopped taking that. It didn't work. And I was like, you got to keep taking it so we can see if it works or not. So,
yeah, or they were started at 100 milligrams
right,
and then
exactly.
never were able to titrate up.
So that's the thing. I always try to start. I try to start generally at 100 unless it's kind of like someone who's, you know, a little younger or just more vibrant in general and doesn't seem like frail at all, or they're a bigger person. I'll give them maybe 300 to start at night, but always at night. And I always say, take this right before you go to bed so that if anything happens, you're just going to sleep and you're going to be fine, by the time you wake up in the morning. Um, and then we can talk about changing the dose from there. And the other thing
Yeah.
is sometimes they have to take it for a couple days, and then those side effects will kind of wear off if they take it for 3-4 days. If they can make it through the first couple days. So if the
Mhm.
side effect really isn't that bad, sometimes they can keep taking it for a couple more days, and then that side effect will wear off. They'll get tolerant to the side effect.
Yeah. And yeah, I tell my patients give it about 45 minutes to start doing anything, lasts about 8 hours. So you kind of have a rough ballpark at least
Yeah.
when it should be working. I would agree with you if we're talking nighttime issues, nortriptyline or amitriptyline seems to work pretty well. I find myself leaning towards nortriptyline just for less side effects.
Mm-hmm.
Uh, Again, if they're younger patients, maybe say younger than 60, I might start at 25 milligrams at bedtime. My typical approach would be if no side effects but no improvement, I'll increase by 25 milligrams every week. Usually, if they're not noticing anything by 75 milligrams, I'll back them off of it. Again, these medicines, when used for depression, they're on 200 milligrams.
Right.
So Usually I can't. I probably have just a handful of patients who are on 75 or 100 milligrams of something like this.
Yeah. The other thing we
If,
should say is if you're taking a higher dose of these medications, you don't want to just stop the medication. So have someone kind of bring you down slowly off of it. There can be some risk with gabapentin. There's a theoretical risk of seizures. And so you just, to be safe as possible, don't just, sometimes the patient comes back like, oh, I stopped taking it. It's like, why'd you stop? Oh, I ran out. Well, that's not good. Don't let yourself run out
uh,
of that medication. Keep taking it and let us kind of bring you back down if you don't want to keep taking it anymore.
yeah. I guess the one thing we should always mention too, especially in the current climate we're in with regards to drug abuse, I know myself, I start to get a lot of pushback even from insurance companies and pharmacies and different pharmacy plans or prescription plans with regards to gabapentin anymore. Because there's reports of people abusing higher dose gabapentin. Um,
Hmm.
so I guess the purpose of me bringing that up would be, don't share your gabapentin. I mean, there are
Oh,
some
yeah.
people out there that if they take enough of it, feel like they can get a little buzz or high off of it. So again, even though it's not an opioid, treat it with respect because there are people abusing this, believe it or not.
Yeah, I haven't run into any issues in terms of like you're saying with insurance companies and stuff, but yeah, I've definitely heard the same thing that you're talking about. So,
You mentioned pregabalin. I mean, very similar to gabapentin. I mean, dosing is different. Obviously, you're either starting at 50 or 75 milligrams usually. But again, slow titration up. Um, the other medicine that I use quite a bit is Cymbalta or
yeah.
duloxetine.
Hmm.
Um, uh, I like it a little better than gabapentin for the fact that it's just a once a day medicine, a little easier to use.
Right.
Again, not my first go-to if patient symptoms are primarily at nighttime.
Hmm.
I've had some people where the norepinephrine part of that medication doesn't really make you tired. It might actually keep you up a little bit.
Yeah, I've seen that.
So yeah,
Definitely seen that. Yeah.
so that's more like a daytime one. If symptoms are really bad during the day, um, and if when you live with chronic pain, you have the risk of becoming depressed or feeling down in the dumps because of the pain. It happens to a lot of people, and it's okay. But sometimes, Cymbalta could be used because it does have some antidepressant effects as well.
Yeah, I tend to use it more when I see that as an issue. If there is some depression and they're not on medication for depression, I tend to maybe lean more towards the duloxetine. But um, otherwise, I don't tend to go to that kind of first line unless that depression is an issue for the patient.
Yeah, yeah. A lot of patients will come over and they're already on venlafaxine, which is
Right,
close relative of duloxetine.
right.
I don't use that too often.
Hmm.
Uh, my understanding of that medication is for pain relief, you really have to get up into the higher doses. Like we're talking like in the 200 milligram range.
Yeah.
Uh, and it's mainly because of how much or the difference between duloxetine and venlafaxine on the norepinephrine uh, reuptake inhibition. So a lot of these antidepressant medicines that help with pain work on serotonin and norepinephrine. The ones that work more on norepinephrine seem to work a little better for pain relief. Um, so, like duloxetine does a little bit more than venlafaxine. So,
Yeah, I don't find myself prescribing venlafaxine, I think ever. Maybe one patient, but um, yeah, I would definitely do duloxetine first. So if that doesn't work, I tend not to go to venlafaxine.
do you ever use
Unless,
milnacipran?
no, I've never used it. I think I've had a couple patients who were taking it already, but I've never used it. What about you?
I feel like the times I've gone to it, I haven't been super impressed.
Mm-hmm.
Right, so milnacipran has even more norepinephrine reuptake inhibition properties.
Mm.
Uh, than duloxetine. So theoretically, it might help even a little bit more with pain, but I haven't seen too much.
Yeah, I think one problem is you have, I mean, as we both have seen, we have our go-to medications for different conditions, and if you're getting to your fifth or sixth medication, either the patient's given up at that point, or the patient's gotten better at that point, or the patient went to see another doctor at that point, you know. Like
Yeah,
there's not too many patients who are going to stick with you through six different medication trials. So which is unfortunate, because a lot of times I tell a patient, I say, look, I don't know if this is going to work, but um, I'm going to try it. It's indicated for what your problem is, and if it doesn't work, we will change, or we will adjust it as needed. But still, you can understand the frustration of someone when you try four different medications and none of them work for their problem. They might start to think, this guy, does he really know what he's talking about? So I could
yeah.
totally understand that. I would think the same thing. So
Do you ever use any other anti-seizure like, meds, such as like carbazepine or anything like that?
not for I've never used it for this, just for like trigeminal neuralgia or something like
Yeah,
that, but
yeah. I
uh,
don't either much.
not for peripheral
I've seen
polyneuropathy.
I've seen some neurologists. I think they probably just they have a little more comfort level with that medicine.
Yeah, yeah,
Use it a little
exactly.
bit more.
Yeah.
Um,
What do you say to a patient if they ask you if there's any injection care for this problem?
oh, that's a good point. So if it is peripheral neuropathy diagnosed on EMG, uh, with regards to nerve blocks, epidurals, nothing, in my opinion, would be indicated for that condition.
Mm-hmm.
Um, now, two things on that. One would be a more advanced interventional procedure, such as spinal cord stimulation, could be.
Mm-hmm.
That can help with peripheral neuropathy, especially when it's debilitating in some of our younger patients. We will do a podcast on that coming up, but that is something that I will at least bring up with some of my patients if we've exhausted everything else and it really interferes with their quality of life. It becomes a risk benefit, especially in our older patients, because there's a lot of comorbidities and they might be on blood thinners and things like that. So you have to take those factors into consideration.
Mm-hmm.
Um, you know, I recently saw, and this really frustrated me, a patient who was given a stem cell injection through a chiropractor's office uh, in the top of his foot for peripheral neuropathy on the bottom of his feet, and he was charged $5,000 for each foot.
Wow.
He was injected with amniotic or umbilical cord stem cells. And I
Wow.
use the air quotes because there are studies that have shown in non-culture expanded tissue. So what is legally available in the United States from amniotic or Wharton's jelly or embryonic tissue does not contain any viable stem cells. They have growth factors and things like that that you have in your own blood, but they do not have actual stem cells.
Yeah.
So, and my understanding, and you'll see this a lot. I mean, it's things will get cracked down, but these stem cell clinics that they could cure anything and everything under the sun. I
Mm-hmm.
mean, um, so I would caution against stem cell use in the United States for peripheral neuropathy.
Well,
If you see that,
I asked the question because I have seen platelet-rich plasma injections for peripheral polyneuropathy, where it was like kind of multiple sub-Q injections throughout the feet, and even like the distal lower extremity.
that'd be
Um,
painful.
yeah, I
Who
don't think
what type of specialist was that?
I think it was an anesthesiologist. Um,
I mean, I guess that
but
doesn't really matter. There's a lot of shady characters. Doesn't matter the
there's shady
specialty.
characters in every specialty in every profession. It's just it was I was just very surprised. I couldn't understand what the patient was trying to explain to me, because I didn't even think that it was like a possible concept to even do that. So yeah, I saw a similar thing, but I think this one was a little more. They did injections all over. I mean, at least they were trying, like all around the foot instead of just on the top of the foot. But um, I don't know.
I mean, we laugh about it, but there's not much more
Look,
than
at
those things
maybe
that
it'll
really
work.
infuriate me.
Maybe someday it'll work if it's done correctly, and we have studies and people study it and it works. But there's no evidence to show that something like that works, and there's no
Well,
kind of like
well, it's all cash. That's the biggest thing.
well, right, that's that's the only thing, that's the reason to do it. But
Yeah.
um if someone studies it and it works, maybe it could help regenerate the nerves. We don't have anything else that helps regenerate the nerves. So there's some chance that that could help some people, but just right now it's not something that is should be being done regularly, is what we should say, probably.
Yeah. Yes. And to
And
my
you can hear
knowledge,
us laughing about it. So, yeah.
the stem cells you can get in the United States, uh, to my knowledge, there's no evidence to support their use for this condition.
Right, exactly.
Um, how about opioids? What are your thoughts on? No, the caveat, we know that opioids aren't that great for chronic nerve pain, but who is a patient that you might consider an opioid with? What is the opioid you might use?
Yeah, I might try tramadol on some people at night for one nighttime dose, if it just because tramadol also is thought to have some kind of serotonin or epinephrine effects, and so maybe that helps with the nerve pain a bit. Also, the opioids can make you sleepy, so um, maybe that's more the effect that patients get at night, is it helps them sleep a little bit. I tend not to go much past tramadol probably for this. I
Mhm.
think that I usually am able to find some good relief for a patient with one of the other medications we talked about, and I'll kind of say, like we've said before, the opioids don't tend to work for this type of pain. So I'm happy to try some tramadol if some of those other things have failed, but I don't think I go beyond that very regularly.
Yeah, yeah. I mean, I would agree with that. I mean, the difficult thing with a lot of the medicines that we mentioned that are not non-opioids for treatment of chronic nerve pain, there's a lot of interactions between them, and then you know there could be side effects. So in some of those patients who might be on a medication that would interact with tramadol, right? Some of the other antidepressants you have to use caution with, or in patients who have been on these medications before and couldn't tolerate them. Uh, I might consider a trial of a low dose of an opioid. Again, um, all that being said, the patient has to be an ideal candidate for a trial of an opioid, and that is another discussion. But some patients who have true pain, it interferes with their quality of life. If the risk of trying an opioid in those patients, for whatever reason, is high, the potential chance of misuse or abuse or even diversion, um, I'll say the risks outweigh the benefit, and we won't even go down that road. But in patients where it seems like it could be appropriate and could be used for functional and quality of life benefits, I might try a low dose of like an oxycodone. In some severe neuropathy, if if the opioid is your only option, the best opioid probably is methadone. In all honesty,
Mm.
um, and low dose every 8 hours. do that in some patients. But yeah, I would agree. It's last kind of route of potential treatment. And you want to exhaust every other option, and you want to make sure the patient is an appropriate candidate for it.
Yeah. Yeah.
Um, how about medical marijuana? Thoughts at all?
Yeah, I don't have too many. I mean, I think there's I don't think we know a ton about it at this point for this. Maybe I don't know. You might know better than me, but I'm not really providing it for patients for this problem. I don't know if you are, but
Yeah.
yeah, there's certainly people who say it helps, but
Yeah, I was actually a little shocked because where I trained, we had access to medical cannabis, and now in my state we do. So I've had a couple years um, of using it now, and when I looked at the studies and what was out there even before I started testing for patients to meet the criteria for it, I thought that these types of patients would do well with the medical cannabis,
mhm.
being primarily nerve-related pain, and with the endocannabinoid system and the CBD or CB1 and 2 receptors, where they're located and how they affect some of these norepinephrine, serotonin, and GABA, glutamate type pathways. I thought it would be good. I I was a little I have been a little underwhelmed by the results for kind of nerve related pain.
Mhm.
Do I have patients that it helps with or it helps for? I do, um, but I also have patients that they don't seem to get any benefit.
Yeah.
Can I predict who does well, um, or who's going to do well? I can't. I don't think there's any good predictive measure that I'm aware of. Um, the big things that I will help to guide my patients with, because one of the big barriers with cannabis is cost right now. So, I mean, I think it's safer than an opioid. So
Right.
I will entertain it in patients, again, who are older, and we're trying to avoid an opioid with, and it's reasonable.
Right.
But if the pain is all the time, you don't want to be smoking marijuana or vaping it, because it
Right.
only lasts an hour or two. So
Right.
it's going to be very costly.
Right.
Um, if it's mainly at night, indica type strain at nighttime, whether sublingual or, I do see patients get some benefit with that. It's difficult to manage the around the clock chronic nerve pain, though,
Mhm.
in my
Yeah.
experience thus far.
Yeah.
But it's another option.
Yeah.
Um, do you use any topicals for this? Like, especially if it's in the feet?
I don't. I know that a little bit before we used to try some of those like compounded creams with like gabapentin in them and whatnot, but um, I never heard great things, and um,
Yeah. And they're
I don't
expensive,
exactly. It was just
and
like too much of a hassle for anyone to get for not much of a benefit. So um, I haven't really used anything like that for this problem now.
yeah, yeah. I mean, sometimes I'll try, like, if the patient's insurance is going to cover even just like a lidocaine and prilocaine mixture.
Hmm.
Um, I try that with even like an anti-inflammatory gel, like a
Hmm.
diclofenac gel, something
Right.
like that. But yeah, I never really prescribe the compounded ones. Very
Right.
rare. It's usually a patient might already be on it. They're coming over for me to take over their care.
Right.
Uh, that I'll continue it for them, but I don't ever start somebody on one.
Got it.
Um, any other treatments that you'll
Yeah, I think we
typically
should
employ?
just I always try to mention to patients to keep an eye on their feet. You gotta they need to keep track of their feet and make sure they're not getting wounds on their feet or cuts on their feet, because if you can't feel your feet, but you don't really know that you can't feel your feet, there's classic stories of patients like stepping on a nail and walking around with a nail in their foot until somebody found it for them because they didn't even feel it. So I always try to make sure, you know, although I'm not an endocrinologist just seeing people with diabetes, you know, we got to keep track of your feet, and we got to make sure that you're not getting wounds on your feet, because if you have neuropathy, you're subject to having skin problems on your feet, which means you're subject to infection of your feet, which means you're subject to amputation of your foot or your leg. So keep track of your feet if you have peripheral neuropathy, definitely.
Yeah, and no matter what the cause of the neuropathy is, I mean, some lifestyle adjustments are required, right? So if it is diabetes, I mean, obviously, great glycemic control. If you're a drinker, it could be the cause of your neuropathy. If it didn't cause a severe neuropathy and we caught it early enough, sometimes stopping the drinking, you can have improvement of symptoms. Even if the issue is from your diabetes, but you're a pretty heavy drinker, you definitely want to cut back because all of that compounding is just going to make the issue worse. Smoking as well, more due to kind of blood supply to the small little vessels that would feed the nerves. All of this, all these little things make a big difference. So there are a lot of lifestyle modifications that are required. One other thing that I should mention in some of my diabetic patients, I'll recommend that they use alpha lipoic acid. So more of a supplement. Again, these things aren't as regulated, so it's kind of tough to recommend one specific brand.
Mm-hmm.
But there was a study in diabetics with painful peripheral neuropathy of alpha lipoic acid. Now, it was in an IV form. Again, we're taking patients are taking a PO form, but it was compared to placebo, and there was a statistically significant improvement in pain. I believe function. It's been a couple of years now since I read that study, but it was IV, 600 milligrams, I believe, daily. So all the patients take 600 milligrams daily of alpha lipoic acid. Most common side effects are usually just a little intestinal kind of upset, irritation when initially taking it. But I'll use that one for my diabetics.
Great.
Or sometimes I'll just use it for any of my neuropathy patients.
Yeah, I mean, it's a great something for patients to try, that you can get over the counter.
Yeah. And then when neuropathy affects the motor nerves, right? So the nerves that give you strength or affect your proprioception, like you mentioned, especially in our older patients, balance could be a big issue. And poor balance leads to falls, leads to fractures, other comorbidities, and other big issues, especially for our elderly patients. So when I see patients who either have impaired gait because of the neuropathy, or balance is off, or they're having falls at home, for that reason, I will get them into some physical therapy. And there were some interesting studies on, well, what kind of therapy would be useful in those patients. And they actually saw coronal plane stabilizers, so like your adductors and your abductors of the hip, and coronal stabilizers of the ankles. Actually, if you train those for power rather than strength, you have a decreased rate of falls. So I'll do that, or I'll send those types of therapy prescriptions over. So I think that's a little different. I mean, when you're training for power, right, speed over time kind of thing. So these are more faster, quick burst type movements.
It makes sense. That's the kind of muscle you need to respond quickly if you're about to fall. So
Mhm.
you need the fast twitch to kind of respond to something like that, or else you can't you're not gonna catch yourself when you're off balance. So it makes sense.
Yeah, I'll tell a lot of my patients, my elderly patients too, like a little home exercise program would be simple things. But if you're at your kitchen table and you're sitting, turn your chair to the side so the table is either on your left or right, so you have something to hold on to. But then you just do a sit to stand. Do that, 10 times each time you're sitting down. Kind of progress from having to use your hands to not using your hands. That really will kind of help to strengthen some of the hip and gluteal musculature. You could buy the little exercise bands at like Dick's or wherever, at Walmart. And when you're sitting watching TV, you could hold them in your hand and you put your underneath your shoe or your foot. You could do a little ankle press downs. I think that can help with ankle proprioception, help with some balance. You could do the little elastic bands that are like the circles, and you can put between both feet. Again, standing but holding on to something. You can move one leg out at a time to help to strengthen some of those coronal stabilizers again. So there's actually a lot of things that patients can do at home to help improve gait speed and balance when you're dealing with neuropathy.
Definitely. Exercise is always great. So
Yeah.
you'll never hear me say a bad word about it unless it's causing you a problem, and then we can talk about how to change it, But
Yeah, without a doubt.
if you're exercising, you're probably doing a good thing.
Yes, I would agree with that.
Yeah.
So I think that was a pretty good overview of peripheral neuropathy, things to look out for, potential treatments that patients could discuss with their doctors, and hopefully some tips. Anything else to add before we sign off?
No, I think that's it. That was good.
Okay, so again, if you missed part of this or want to review, you could check out our YouTube page. If you have any comments, please feel free to leave them. You could also contact us at our Facebook page. If there's any specific topics you'd like us to discuss in future podcasts, we are always open to suggestions. So, Dr. Bonner, have a great night. Enjoy that warm weather.
It's a little cold, but I will.
Okay.
All right. See you.